Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. This webinar is titled Leaky Bladder and Pelvic Prolapse, When and Why You Should See a Urogynecologist. The presenting provider is Trinity Health IHA Medical Group Urogynecologist James Ross. Dr. Ross sees patients at our newest practice for women, Trinity Health IHA Medical Group Urogynecology in Bloomfield, and it is located at Woodward and Square Lake Roads in the same suite as our OB-GYN practice. Welcome, Dr. Ross.
Thank you. Can you hear me?
Yes, perfect.
Awesome. Great. Well, thank you everybody for taking the time this evening to log in and listen to me talk about what I love to do every day, treat women with leaky bladders and prolapse. So I'm just going to start. Great. All right. So what are we going to do in this talk this evening? So I want to address what is a urogynecologist? What exactly is the pelvic floor? Like, what does that mean when I talk to patients about their pelvic floor? What is considered a pelvic floor disorder? And when should you as the patient seek care for these symptoms? And then what treatments can be offered for these issues? I just want to first start just so you get to know me a little bit. I'm born and raised right here in Bloomfield Township. I went to WashU in St. Louis for undergrad. There's a beautiful picture of the arch. And then I went across to the East Coast to New York Medical College, just outside of New York City in Westchester County. I did my residency in obstetrics and gynecology at the University of Pittsburgh Medical Center's Magee Women's Hospital and had fantastic training there. And then I finished my very long training in fellowship at the Cleveland Clinic, just a state away in beautiful Cleveland, Ohio. And I'm very happy to be here now back home practicing. So I first just want to address the simple idea of what is urogynecology. So essentially, urogynecology is a hybrid specialty or subspecialty with a mix of urology and a mix of gynecology. It's specialized training, meaning most people nowadays who practice it underwent training beyond an OB/GYN or urology residency and complete a fellowship in urogynecology and reconstructive pelvic surgery, which is, in my case, an additional 3 years after a 4-year OB/GYN residency. And urogynecologists, our primary focus is on improving the quality of life of patients in regards to their pelvic floor, whether that's leaky bladders, overactive bladders, weakened pelvic floor muscles that lead to these conditions, along with prolapse, bowel issues, sometimes pelvic pain, and anything else that really impacts your quality of life as a patient related to your pelvic area. In general, my referrals typically come from primary care doctors. So whether you see an internist, you see a family doc, or you get your care from your OB/GYN, a lot of those patients I see come from them because they're usually the first line of defense in terms of asking questions about how your bladder behaves, how your gynecologic organs are, and you usually see them more frequently. Also, of course, self-referrals are very welcome if you're not having primary care and you still have these problems, feel free. It's also important to continue care with an OB/GYN or a urologist for certain issues, even though you're seeing a urogynecologist for care, whether that's seeing your OB/GYN for pap smears, getting your mammograms, talking about contraception, bleeding, infections, or pain, or seeing a urologist if you have issues like kidney stones, if you have abnormal issues with your urinary system like masses or abnormal cells, if you have visible blood in your urine, or if you have trouble urinating, urologists are more of the right person to continue care with for those issues. Because although urogynecology is kind of a transection of both these specialties, it doesn't cover everything. So I just want to give a little bit of a talk about what is the pelvic floor, just kind of help everybody understand the issues that are going on with them. So I want you to envision the pelvis as a bowl. You have your pubic bone, which is essentially the structure that forms this bowl. And then within this bowl, your organs are held. So you have your uterus, which is this middle pink organ, which has a cervix, which may or may not have some tubes and ovaries attached to it. You also have your bladder leading out with the urethra, which is the tube that takes the pee out from the bladder. And then you have your bowels, which is your rectum. And then supporting that, you can see here in this picture, is your pelvic floor. So you can literally see how this is the floor of everything holding this up. And you have all kinds of muscles in that area called the levator ani muscles, called the obturator muscles. They're all these muscles that work in conjunction that hold everything in place. And that when they start to fail or when there are issues with them, that's when we start to see some of these conditions that I treat. So, talking about the conditions, the overarching term is pelvic floor disorders. So, 1 in 4 women will suffer from a pelvic floor disorder, although that is likely underreported due to um, many factors, such as it not being asked about at doctor's offices, patients being embarrassed or unsure of how to talk about it. So it probably is much more frequent than 25%. Bladder issues in themselves, such as urgency, frequency, leakage, may affect up to 50% of women. And we know as women get older, these issues become way more frequent. And one of the biggest points I want everybody to take away from this talk is these issues are not normal at any age. I know the teaching for a long time, and whether it's been passed down through families, been talked about in the media, whatever, is, this is just part of aging. None of this is normal. None of this is something that you as a patient need to suffer through. And these are things that should and can be treated. And it's not something you just have to tolerate. This is just a Venn diagram showing how frequent some of these issues are. But also what's important here is they all have overlap. So just because somebody has bladder issues doesn't mean that they're not also going to have bowel issues, doesn't mean they're also may not have some prolapse or the weakening and the dropping of the pelvic organs. Everything kind of works in conjunction. And so a lot of the times when there's one issue, there may be multiple issues. So you're not alone if you're suffering from not just one of these, but multiple of them. I probably don't have to tell a lot of you on this webinar, it's costly to have pelvic floor issues. This is more related to the bladder than the other ones, but looking at this diagram, pads and laundry, depends, panty liners, all the incontinence things that you have to buy and dispose of all the time, they take up a 30%, 37% of the 25 billion cost related to incontinence and bladder issues. It's also consequences related to this, whether it's infections, irritation, other medical conditions that relate to this, whether it's community caretaking related to this. And it's interesting that of all of the costs, treatment and evaluation actually is the cheapest because of how common it is and how few people actually reach out and get treated for this. Now, how does somebody end up with a pelvic floor disorder? It's a tough question to answer whenever I see patients, but there are a lot of risk factors. Obviously, one of the biggest, most common and well-known ones is pregnancy, childbirth, especially vaginal delivery, aging and menopause related to the estrogen responsiveness of women's vaginal tissue and how as you become menopausal, that kind of goes away. People who suffer from chronic constipation and are straining a lot to have bowel movements put you at risk for pelvic floor issues. Weight gain and obesity, people who carry extra weight in their abdomen and their belly area, it does put extra pressure on those organs and your pelvic floor. There's also a genetic predisposition, especially in patients who may have connective tissue disorders, whether it's a known one that people have a diagnosis of, or whether you just have some loose joints, and then things in other areas also can be a little more flexible. Stress and anxiety can be a risk factor as well. And that's because a lot of people who are stressed and anxious, they can put a lot of tension and strain on their pelvic floor, which over time can cause some of these issues. And of course, people who've had prior surgery in that area, possibly if you've had cancer treatments, whether it's radiation to the pelvis, can certainly cause this as well or be a risk factor. And then a lot of women who are very active in terms of heavy lifting on their jobs. I see a lot, of nurses, people who are caretakers that are lifting patients, people who, have a farm and are out pushing, equipment and lifting and doing a lot of bending. I see that a lot in my patients as well. So a lot of risk factors. It's really unavoidable to have some of these. Some of them, of course, can be mitigated, but just, I want patients to know that a lot of the times there's nothing you can kind of control or do to have prevented the situation. One of the pelvic floor disorders we're going to talk about is stress urinary incontinence, or SUI. That's when you have leakage with coughing, laughing, sneezing, exercise. You're doing jumping jacks, you're running, you're lifting weights, you're lifting groceries, you have an accident. That's stress incontinence. That's more of when kind of the muscles that control the opening that lets the urine out start to have some issues, and the support to that start to have some issues. There's also overactive bladder, and along with that is more of an urgency related incontinence. So, overactive bladder is a syndrome that encompasses multiple things like frequency, going all the time, and that is a little subjective. It's can be, 5 times if your normal is two, it can be going 10 to 15 times a day. It really can be what is more bothersome to you as the patient. And of course, having severe urgency, so feeling the need to go, always needing to plan out like where is the next rest stop? I need to know where the bathroom is at the grocery store because I know I'm going to have to go. And then the term nocturia means getting up at night to go. It's normal to get up maybe once or twice a night to go pee, but if you're getting up, 3, 4, 5 times, losing sleep, exhausted during the day, that's abnormal. And then of course, this can all be associated with leakage. So, patients are running to the bathroom like this person here, and if you're not making it, then you have that urgency incontinence. And then there's a mixed incontinence. So those are patients who have, you have both stress related, so you cough, sneeze, leak, and you also have urgency incontinence. So you run into the bathroom, you're not getting there in time. And it's incredibly common to have both of these at the same time. Bowel issues are also within pelvic floor disorders, and that can be either constipation, so, not going to the bathroom very frequently, having a hard consistency, maybe having little pellets come out, and really needing to push or strain and not feeling like you get all that bowel movement out. And then on the opposite end of the spectrum is accidental bowel leakage or fecal incontinence, which is more of having bowel accidents, maybe not be able to kind of clean up fully all the time, even having, just leakage of gas as well. And then, of course, the other pelvic floor disorder is pelvic organ prolapse. So that relates to issues with pelvic floor weakening. And that leads to essentially a vaginal hernia where your other organs are kind of pushing out through the vaginal area. And that can cause symptoms of bulge or pressure. You feel like maybe you're sitting on something between like maybe a golf ball up to even maybe a grapefruit. Can cause bleeding, can create difficulty using the bathroom. Patients need to maybe put their fingers in and around that area to have a bowel movement or to urinate. Can also, when it's a little worse, even cause issues with intercourse. Now, when we talk about prolapse, it can be a combination of any of the three different compartments or parts protruding into the vagina. And what I mean by that is it can be something like a cystocele, you may have heard the term, or bladder fallen or bladder prolapse. And that's more when the kind of upper part of the vagina, that where the bladder is sitting, protrudes or herniates into the vagina. That leads to the sensation of bulge or pressure. It can cause urinary symptoms. It can cause those overactive bladder symptoms like urgency, frequency, needing to go to the bathroom all the time. If it's really severe, patients may even need to put their fingers in and around the vagina to help the bladder empty. There's also uterine prolapse, where the uterus and cervix is prolapsing out. If you've had a hysterectomy, you can also have a vaginal vault prolapse. That's where the top of the vagina, where the uterus used to sit, is prolapsing and coming out. That leads to those same bulge symptoms. And then there's also a rectocele. So that is different than rectal prolapse. Rectal prolapse is when the rectum itself is prolapsing out of like the anal area. A rectocele is when the rectum is protruding into the vagina. And a lot of the times, patients who have rectoceles have a lot of bowel issues. They have constipation. They feel like it's getting stuck. They sometimes need to push really hard or even do something called splinting. And that's where you're kind of putting your fingers in and around the vagina to help push out the bowels to empty. And so when do you seek care for these problems? There really is no right time. It's okay to be proactive for a pelvic health assessment if you are at all concerned, but essentially, it is absolutely up to each and individual patient when they feel like they're bothered by these issues and want help and want to seek care for this. I, as a urogynecologist, am accustomed to meeting patients at all life stages. A lot of the times, these are particularly when patients are feeling very vulnerable, whether it's postpartum, when the pelvic floor is healing from like the trauma of birth and they're having incontinence, feeling prolapse or bulge down there. Um, whether it's patients entering menopause when they're starting to get bladder symptoms, when they're starting to experience genitourinary syndrome of menopause, which is kind of a newer term that encompasses all that the dryness, some itching, some of the bladder symptoms related to that lack of estrogen down there. But in general, the right time to establish care is when symptoms are bothersome. And my job as a urogynecologist is to establish a safe environment to discuss these sensitive problems and to change the stigma that this is a normal part of aging. I know I said it already, and I'll probably say it again before we're done, but this is not a normal part of aging, and it is something that should be treated and cared for. And my job is also to educate that these are very common, yet they're rarely spoken about because they patients tend to find that they're embarrassing to discuss. But, I would just wanted to provide reassurance that, as a urogynecologist, I do this every day and I hear people's stories all the time, and it should be nothing to be ashamed of to talk about. And I strongly encourage everybody to feel empowered to discuss this. And of course, my job is to collaborate with patients to meet their quality of life goals. Everybody's goals are different and how they want to approach it is different. And it's my job to tailor those approaches. So what to expect at the office. So I'll talk to you about your symptoms and get your medical history. You'll get a physical exam, which mostly includes a pelvic exam. If you have any prolapse, you'll be asked to kind of bear down or push during the exam, which I know can be a little strange, but it allows us as urogynecologists to see the extent if it's prolapse or even to check for prolapse, even if it's for bladder issues or other things. You will also be asked to cough during your exam, and that's to check for things like that stress incontinence. Of course, you can always refuse a pelvic exam if you are ever uncomfortable. There will never be a time when it is 100% required if it's not something you want to do. Other things that will happen in the office, generally, we'll have you urinate and we'll dip it to get a result to make sure there's not an infection. As a urogyne, I also treat people who have issues like recurrent bladder infections and bladder pain. Also, there may be additional bladder testing. I tend to do a little bladder ultrasound at each new patient visit just to make sure it's emptying okay. And then there may be further testing depending on your symptoms and complaints. Sometimes urodynamics, which is kind of it's bladder function testing, may be done, whether the check for how your bladder is behaving, whether the check for the leakage, that's an in-office test. We also may perform a cystoscopy where we take a look in your bladder with a little camera just to make sure everything looks okay as well. So what are your treatment options for all these conditions I just talked about? So in most cases, I talk to patients about everything, which can be very overwhelming at a visit, but I try to kind of keep things simple as well. The one thing I always tell people, you never have to do something about it. You can educate you about it. You can always elect to not do anything because these are quality of life issues and it's about what you as the patient want to do. In general, though, there are some simple things I offer to patients as first line therapies, which are more conservative, such as behavioral changes. So patients who have overactive bladder, urgency and frequency, talk about dietary and fluid management. So cutting things out like sodas, citruses, alcohol, cutting down on coffee and tea, all of those things that can be bladder irritants. Talking about how to retrain your bladder to give yourself more time in between going to the bathroom. A lot of patients suffer from key and lock syndrome where, as soon as you get home and you start to walk to the door and unlock the door, whoosh, you get the urgency, you're running to the bathroom and you're not making it. So trying to teach people to kind of do timed contractions, be calm and take deep breaths and get to the bathroom without rushing is kind of one example of that. One of my favorite conservative therapies for almost all pelvic floor conditions is pelvic floor physical therapy. A lot of the times this can be things you learn at home, but I always strongly encourage patients to go to a pelvic floor physical therapist. These are physical therapists who are specially trained to treat these conditions. And it's not like going to a big physical therapy gym. You may go to a physical therapy gym, but they have separate private rooms. These physical therapists take their time with you. A lot of the times they do internal assessments like I would do myself, like an exam, and really help make sure that those muscles are working in the way that they're supposed to. It does take time, it does take commitment, but it works. Further treatment beyond kind of being more conservative for overactive bladder specifically, or the leakage associated with urgency or medications. I'm sure many of you have tried some of these medications like oxybutynin, Vesicare, Sanctura. There's many out there. They're called anticholinergics. They can dry you up. They cause dry mouth, dry eyes. We're starting to also see that they can put people at risk for dementia. So I really don't like to prescribe them, even though insurance companies tend to like me to do that first. There are other medications called Mirbedrica and Gemtesa that don't carry those same side effects, which I tend to like a lot better. Um, they tend to be a little bit more expensive, but we're getting a little more creative with how to make it affordable for patients. And then there's also things like vaginal estrogen cream, which may help improve the overall health of the bladder and vagina by using. Beyond medications for overactive bladder and the urgency leak are more procedural options. So one of those options is bladder injections of Botox. So this is a procedure that's done either in the office or in a surgery center where we use a little cystoscopy. So we take a look in your bladder and then we inject Botox at multiple points of your bladder. And what that does is it kind of freezes up the bladder muscle. So those bladders that are spasming, that constantly want to empty because of the overactivity, they relax. It's a very good treatment. It lasts about 6 to 12 months, and it's something that just continues to get repeated as long as you as the patient are getting the results you want from it. The dosages can be increased sometimes. It's in general is very well tolerated, and I tend to have very happy patients after Botox. The good thing with Botox is it's not a permanent treatment. So if sometimes it works too well and the bladder freezes too much, none of it stays for a long time. Another more invasive treatment for overactive bladder is nerve stimulators. So there's two types of nerve stimulators we use to treat overactive bladder. This is a picture of, it's called sacral neuromodulation. Essentially, it's a pacemaker that we put in the buttocks area, and we have a wire that goes down to the sacral nerve, and it can help control the bladder. It kind of continues to fire the stimulation that we don't really have a great idea why it works, but we just know it disrupts some sort of signal to the bladder and helps it relax. It's a small surgery, so it's usually done in 2 stages where you test it out first. So we want to make sure it works before we really put a permanent implant in somebody. And then once that implant is in, there's ways to reprogram it, change the stimulation. We work very closely with our industry sponsors and their reps who help us, essentially program these devices with patients. And it's also a very nice, more invasive procedure for overactive bladder. There's a different nerve stimulator called tibial nerve stimulation. It's more like acupuncture. I don't have a picture of it here, but it's a little needle that goes in the ankle, and you come to the office every week for 12 weeks, and then you come back every month for maintenance. It's a little less invasive. The studies don't support it quite as well, but it's another option for patients. We don't quite have it yet in our office in Bloomfield, but if I start to have patient interest, it's something I'll certainly look into. And they're actually going to start coming out with implantable ankle devices now, is more similar to that neuromodulator picture here, which may make it easier to offer as well. Now, in terms of stress incontinence, besides, of course, pelvic floor physical therapy, which I think is an incredible treatment, or at least a good adjuvant treatment for patients with stress incontinence, more conservative therapies involve vaginal inserts. So whether that's a pessary with a knob that you can see on your right, or they make these little disposable, they're almost like tampons that go in the vagina. They put pressure on the urethra through the vagina, so they allow you to kind of block it off or occlude it whenever you wear the device. And these devices can be taken in and out as frequently as you want, whether you're a runner and you only leak with running, then you can put something like this in when you go for a run, and then when you're done, you can take it out. It works for some patients, but other patients just want more of a fix. So for those patients, we can offer more procedural interventions that allow the incontinence to be treated. One of those is called urethral bulking. I try to describe it like filler, but for the urethra. So we take this kind of gel material and we use that little cystoscope, that little camera, and we inject it right where the urethra meets the bladder, and we create these kind of cushions or pillows in that area, which bulk it up. So essentially what we're doing is we're making it harder for the urine to come out when you cough, when you sneeze, when you laugh. And this is a procedure that is either done outpatient in the office under some injections, numbing injections, or under some light anesthesia in like a surgical center. Right now, I'm offering it in the surgical center. We don't quite have it in the office yet, but I do think it is a nice procedure to do in the office because you can avoid things like anesthesia and get this done. The other treatment for stress incontinence, which is by far the most popular that I'm sure there are many of you out there who've had it done, or you know many people who've had it done, is a bladder sling, which that's kind of more of the common term for it. But really what it is, it's a urethral sling. So what this is it's a little piece of this permanent mesh that sits under the urethra. It essentially acts as like a hammock. So when people cough or sneeze, it provides this like backstop to prevent the angle changing so that you have this leakage. Um, it's a short surgery, takes about 20 to 30 minutes in and out of the hospital same day, little incision in the vagina. And I do want to just say, I know there is a bad rap for things like mesh products in the vagina that's been out in the, in the public. The mesh we use for these slings is incredibly safe. It's been studied very thoroughly. And in general, there are minimal to no complications related to it. But I do understand if patients are apprehensive about mesh, then we talk about the other options. But this right now is considered more of like a gold standard treatment, meaning it's like the premier treatment for stress incontinence. But I will say bulking is becoming more and more popular as we've gotten kind of some new materials we've been able to inject with. So that may switch at some point, but I think they're both really good treatments, and I'm happy to offer any of them to patients who suffer stress incontinence. So when we're talking about prolapse now, again, pelvic floor physical therapy is a good treatment. Not quite as effective as treatment for bladder issues. But when we're talking about more conservative therapies, I'm talking more about something like a pessary. So there are a lot of different types of pessaries, as you can see here. There's all kinds of shapes and sizes. There's even something called a donut. There's something called a cube. There are all kinds of sizes as well. The most common ones are a ring pessary, which is just a ring and it has a little bit of a surface in it, and that just gets put in the vagina. A ring pessary is something that you as a patient may be able to manage yourself. So there are plenty of people out there who take them in and out when they want, clean them and put them back in. And then there are other types of pessaries called a Gellhorn was one of them. And those are pessaries that maybe saved for more severe prolapse. And those are pessaries that, in general, patients aren't able to manage themselves. They kind of have a suction to them, so they are hard to take out. So a lot of the times, patients who have Gellhorn pessaries are coming back to the office every, 3 to 4 months to have myself or a different provider take it out, clean it, and put it back in. In general, pessaries are very nice treatment, especially for patients who want to avoid surgery. There are certainly scenarios where the pessary just doesn't work. And when you come to the office, and if you're interested in a pessary, we try to fit you for it. So we have a fitting kit. I kind of describe it almost like, trying on a pair of shoes, which I know is a little strange, but what we do is we put a size in, we have you get up, we have you walk around the room a little bit, and then we actually have you go to the bathroom and sit over the toilet and kind of push down and simulate going to the bathroom because I want to make sure it's not going to fall out. And if it doesn't fall out, then that's a good size. It still may fall out at home at some point, but in general, we're able to mostly successfully fit a pessary, but there are scenarios where it may not just work for that person's, anatomy and their organs down there. And whether it doesn't work or whether you're, as a patient, say, I don't want this pessary device, I just want to talk about a more permanent fix, then we're talking about surgery. So surgery for prolapse in general is performed by a urogynecologist. There are other people out there who are performing prolapse surgery, but as a urogynecologist, I perform surgery for prolapse. They're all a minimally invasive approach, and every case is different. I can offer robotic or laparoscopic surgery. I can offer surgery only through the vagina with no incisions in the belly. It's all individualized. In terms of the vaginal approaches to surgery, there are a couple different kinds. vaginal surgery for prolapse can or cannot involve a hysterectomy. It depends on the conversation I have with you as the patient. There are some patients who say, my uterus, means something to me. It, defines my, womanhood. I don't feel like we need to take it out. And then there are other patients who say, it's not doing anything for me anymore. Like, just let's get everything out that we can. Either way, through the vagina, what I do is attach the vagina, the uterus, whatever stays in there, to your own ligaments and tissues just using sutures. So we can either do that using the uterosacral ligaments of the pelvis. Usually I do that after a hysterectomy. So we close up the vagina, then we push it back up. Or we can do that through attaching it to someone's sacrospinous ligament, which is just a different ligament in the pelvic area. That's more of a surgery I personally say for patients who already have had a hysterectomy in the past and have had more of a vaginal vault prolapse, and then you're able to just push that vault back up and attach it to one of those ligaments. They're both really nice surgeries. They both have high success rates. I do want to just say none of these fixes are ever 100% perfect. They also never 100% have full longevity, meaning there is the possibility, no matter how well a surgery is done, that you have recurrence of the prolapse. There's also the mesh related surgery, which is called the sacrocolpopexy. And what that is it's done through either robotics or traditional laparoscopy, where the doctor is actually standing at the patient bedside using the instruments. And what usually happens is a hysterectomy is done if there's still a uterus. We usually leave the cervix for that. Or if there's not a uterus, you just do that mesh repair. And what this is it looks like a Y. So it has three arms to it. And two of the arms are attached to the vagina on the upper and lower part, and the cervix if we leave that in. And then the other piece of mesh is actually tied to your tailbone. And this is a very durable repair because the mesh is permanent. So it provides kind of structure for everything to kind of scar to and heal to. So this surgery may have a little bit more durability than the other ones I've talked about. But again, everybody's opinions about mesh are different. Everybody's opinions about kind of their goals and what approach they want is different. So I always work with the patient about what works best for them. And then in terms of accidental bowel leakage, there's quite a few treatments as well. Talking about dietary changes, I have patients who say this only happens when I, eat cheese or drink milk. And so we talk about, changing your diet, keeping a diary of when this is happening so you can keep track of what you're eating, um, preventing constipation and loose stool. So whether that is through diet, whether that's through increasing your fiber, whether that's through taking things like Imodium, um, again, pelvic floor physical therapy. There's bulking procedures for that if a patient wants, I refer to my colleagues in colorectal surgery. That same sacral nerve stimulator is a treatment not only for overactive bladder, but also for fecal incontinence or bowel leakage. Then also, in some of the more severe cases, there may be surgery related to that, such as a sphincteroplasty, where you kind of bring the anal sphincter back together. It's a little bit more morbid, so I tend to avoid that if possible, but that is an option as well. And then, of course, one of the great things about my specialty is that I get to collaborate with so many other practitioners, whether it's physical therapists, who I've had the pleasure of meeting quite a few in the Metro Detroit area since I've moved back here, talking with nutritionists, working with gastroenterologists, which is especially important for patients who suffer from the bowel issues. A lot of the times, if that constipation is not necessarily related to things getting stuck down there, it can be more of a motility issue, and that is more of a gastroenterologist specialty. And of course, I work very closely with colorectal surgery. There are many patients out there who suffer from both rectal prolapse and vaginal prolapse, and we have a great colorectal surgeon with IHA in the Oakland region, Dr. Monica James, who I do surgeries with in a combined fashion to fix both of these. And then, of course, I work with neurologists, especially neurologists who treat patients who have neurogenic bladder, so things like multiple sclerosis, brain injuries, those kind of things. They present the same as overactive bladder, and they require some of the similar treatments. And of course, I'm always coordinating with your primary care doctors, your OBGYNs, your urologists, and whoever else needs to be a part of your care. So, conclusion, care for the pelvic floor addresses issues with urination, bowel movements, and your pelvic floor muscles. Management of urogynecologic disorders such as bladder leakage, overactive bladder, and pelvic floor weakness can range from conservative treatment to surgery. The choice is really up to you, in a shared decision with your surgeon. And then the biggest takeaway I want you to understand is pelvic floor disorders are common. Regardless of age or circumstance, you should not feel embarrassed to make an appointment to discuss potential treatment options. It is not normal. You don't have to tolerate it. And there are amazing doctors out there who are happy to treat you for these problems. So please don't hesitate to make an appointment. And I am happy to answer all of your wonderful questions.
Okay, thank you, Dr. Ross. So we do have quite a few questions already, so we will get
Great.
started with those. If you do have
Sure.
a question and you haven't asked it yet, you can do so by dropping it into the Q&A feature at the bottom of your screen. And again, you can ask questions anonymously. Just make sure to select that before submitting. Okay, so we'll jump right in. Is there an age limit on surgery for any of these problems? Also, would having a pacemaker limit this surgery?
It's a good question. In reality, there is no age limit for surgery for these problems. Again, it just depends on each individual patient. It depends on their health. It depends on what other kind of medical problems they're dealing with. And then, of course, you can tailor somebody the approach. There, we also offer something called an obliterative surgery. So if a patient's older, if they have severe prolapse, we can try to minimize their time under anesthesia, minimize their blood loss, and essentially just kind of close everything off, which I didn't talk about that approach as well. But I try to tailor everything. I try never to say no, no, you're not a good candidate if the patient really wants or needs it. But there certainly are reasons why I wouldn't do a surgery, but age is usually never one of them.
Okay, it really sounds like if you're struggling with any of these issues, making an appointment is a great first step because the conversation with you can really solve a lot, it sounds like.
Mhm.
Okay, so this person had a bladder sling about 12 years ago. They were good for a few years, and now in their late 50s, it's worse than ever. Can they have surgery again?
Yes, definitely. I certainly have experienced many patients who have had a sling many years ago, and then whether it moved, whether it wasn't quite in the right place to begin with, whether, as you age, again, if the pelvic floor muscles have changed, then that sling may not be sitting in the same place. And you can absolutely get another one placed. There's also other options, such as that bulking procedure I talked about, which can certainly be done even with the sling in place. Yeah, it's having just one sling is not the end of the road for treatment for leakage.
Okay, and does bulking cause more frequent UTIs?
So not generally. What does cause UTIs is any procedure that happens when you get something introduced into your bladder or your urethra. So whenever you have a procedure like that, or whether you have, any sort of pelvic floor surgery, you are at a little bit of an increased risk for a UTI. The only way bulking may increase your risk for UTI is if it works too well and the patient can't empty their bladder as well, they may have a little bit of a retention problem. But if that is a problem, it's something that should be addressed, and that should be resolved, and then it really shouldn't be a problem.
Okay, and if you do find yourself with a UTI, is it treated in like a similar way as pre-surgery or pre-procedure?
In general, yes. Usually post-procedure UTIs get a little bit of a longer course of antibiotics, but it's the same type of antibiotics, the same workup, the same. You get a urine culture to see what kind of bacteria is in there and all of that.
Okay. Okay, this person is saying they had 2 rounds of pelvic floor therapy and are still having issues. The main annoyance is that she loses bladder control every time she has an orgasm, even if it's shortly after emptying her
Mhm.
bladder. It has been happening for 3 years now. Would I be able to get this to stop with help from a urogynecologist?
Yeah, this is certainly something that I've seen. Absolutely, it sounds more like stress incontinence related, meaning, kind of the spasms and people leak with intercourse. It may require something like urodynamics just to confirm and make sure, but yeah, absolutely, if the pelvic floor physical therapy is not working or helping enough, I think seeing a urogynecologist is a great next step.
Okay. So we've had actually Dr. James, Monica James spoke back in the spring, And she did talk about using a squatty potty. So is there a similar advantage to squatting for urination? So does that allow more complete voiding? And does squatting strengthen the pelvic region?
I don't know if I've ever actually thought about that or gotten that kind of question. In general, the best way to kind of help yourself empty your bladder, urinate is not necessarily squatting, but it's more of kind of like leaning or bending over while you're sitting, because that's going to put the pressure on your bladder to help it empty a little bit more. You can also kind of push over your pubic bone, and that'll help your bladder empty as well. So not necessarily this action of squatting, but more of like the kind of bending over to put pressure on your bladder.
Okay. Okay, at what level of stress incontinence is appropriate for a urogynecologist versus a urologist?
It's a very good question. There is no, I guess, level. It really just depends on who you are able to see at a convenient location and who can see you. There are plenty of urologists who, are trained to place slings, do the urodynamics, work all that up. My plug is always going to be to see a urogynecologist as a female with stress incontinence, just because, our training is a little bit more specialized in treating female pelvic floor issues, but certainly there are many, many, many good urologists out there who can provide you with excellent treatment as well. I don't have a great answer for one versus the other. My best answer is who you can get in to see and who you think is a good doctor for you.
Okay. Well, this person has multiple sclerosis. She's had Botox, but it doesn't seem to be working anymore. She now has an implant that might help slightly, but is looking for another suggestion for bladder incontinence. Are there other things she can do?
It's really tough. As somebody who has MS who has had Botox in a sling, that may be something to best talk to somebody in the office about, because your options are getting a little bit more limited that time. Talking more about something like maybe a suprapubic catheter or something kind of a little bit more permanent, just because those issues are a little different, and you've kind of done everything you can from the other procedures.
Okay. So there are several people who've asked about physical therapy, but physical
Mhm.
therapy is not typically a first step, correct? Like they would need to see you and then have a prescription to actually go to physical
Sure.
therapy, correct?
Yeah, so I think it depends. The state of Michigan may actually be getting rid of the requirement to need a referral at some point. But in general, I mean, feel free to ask your primary care, feel free to ask your OBGYN for a referral to pelvic floor PT. It doesn't have to be a subspecialist to give that referral. And then essentially how you find a pelvic floor physical therapist. Um, there are websites. I think pelvicrehab.com has a pelvic floor searcher. That tells you it's tough to find a pelvic floor physical therapist, because not every physical therapy company or location has somebody specialized to do that. So going online, I have a bunch of lists in my office that I'm happy to provide referrals for as well. But it can be a little tricky.
Okay. And can Botox be used while going through physical therapy?
Yeah, absolutely. Any of the treatments I've talked about can be done at the same time as physical therapy. Sometimes I would even recommend patients who've had a sling or are getting Botox or had an implant put in do physical therapy either leading up to the procedure or even kind of as an additional treatment afterwards. It's only going to help. It's not going to do any harm.
Okay, I didn't realize that. So it isn't necessarily an either or situation.
Right.
Be doing
Oh,
both.
it can all be done. Yep.
Awesome. Okay. This person has a daughter who has spastic cerebral palsy. Can Botox injections be given in the pelvic floor or just the bladder?
It's a very good question. Absolutely. I do offer, if I see patients who have like a high tone pelvic floor or pelvic floor spasms, I definitely offer patients Botox injections into the pelvic floor muscles. I usually do that in the operating room under anesthesia, and we, just do a bunch of injections into the vagina to get to their pelvic floor muscles.
Okay. How do pessaries or other inserted items react with toxic shock syndrome?
It's a good question. In general, pessaries, because they're a silicone device, and they don't kind of absorb blood like a tampon would, that where you get that infection buildup. They don't really relate to toxic to shock syndrome. They can lead to things like bacterial vaginosis and kind of just dysbiosis of the the bacteria, the good bacteria in the vagina sometimes. But a pessary is not going to lead to toxic shock syndrome.
Okay. I know that toxic shock syndrome, it's like a classic back of tampon box warning.
Hmm. Hmm.
I'm sure every woman has seen at some point in their life. Um, so this person has a pessary and they've had it since 2022 and
Okay.
go every 4 months to have it cleaned and reinserted. Will prolapse eventually heal itself, or is this a lifelong situation?
So prolapse is a lifelong situation. Sometimes it may go back up a little bit. Sometimes it may come back out a little bit more. Sometimes it may progress from stage, 2 to stage 3 to stage 4. It's not something that is self-healing. It's also hard to predict whether where you're at now is going to be the same as what you're at in 5 years or whether it's going to get worse. But it's definitely not going to kind of go back up and stay up.
Okay. Can you talk a little bit about the recovery time if surgery is required for a prolapse? Like what that
Sure.
might look like?
It does depend a little bit on the type of surgery, but if we're just talking about kind of a general hysterectomy with prolapse repair, usually patients are getting a full 6 weeks for recovery. I tend to try to get patients home the same day because I think in general you're recovering better at home. Um, and in general, I probably by like 2 weeks or so, you're probably back to like 80% of what your energy and feeling wellness will be, but it takes probably a good 6 weeks to really feel like you're recovered from something like that.
And will you see improvements in your symptoms right away, or is that about 6 weeks as well?
Oh, yeah, I mean, if we're doing surgery for prolapse or there's a bulge, it's immediate. Like that bulge is gone.
Okay. Do you have recommendations on what kinds of questions a patient should ask a pelvic PT provider about their
Mhm.
training, expectations for improvement,
Sure.
things along those lines?
That's a good question. I think in general, just making sure that they have some sort of official training and are well versed in the conditions. I also always want you to make sure that your pelvic floor PT is doing internal work. There are some PTs who kind of just do breathing and core and diaphragm and glutes, but it's really important to have somebody who knows how to do an internal exam and assess your pelvic floor muscles. So in my mind, that's the most important thing you should make sure of is that somebody's well versed in doing internal work and making sure that you're recruiting the right muscles and doing all of that.
Okay. Before you perform surgery, do you recommend weight loss for patients?
It depends on the patient. It really does. Um, in general, I don't just because I know that's a big ask and it's something that, it may not be a very attainable thing depending on the patient in terms of how much is needed. But it really is dependent on each individual patient. But in general, no.
Okay. So you talked a little bit about proactive appointments and talking about some of these issues proactively. If you do get a pessary before you have severe symptoms, is that something that can prevent the progression of uterine prolapse or any of the other pelvic floor issues?
It's a good question. It's been studied and there's like maybe a little bit of data that shows early intervention probably can even cause maybe it going from a stage 1 to stage 2 for a little bit. But in general, if you get a pessary for like a more, and I apologize, I don't think I actually ever talked about prolapse stages, but it's just based on how far out of the vagina everything is. So it goes from stage 1 all the way to stage 4, which is essentially everything that was on the inside is kind of on the outside. Um, but in general, I would say it's hard to predict what's going to happen to prolapse, regardless of what stage you start at and when you start your pessary.
Okay. We have a couple women who are asking about exercise kind of in your 70s and 80s. Are
Mhm.
some of those Kegel exercises that can be done at home for stress incontinence useful at that age?
Yes, definitely. The one thing I do want to caution though is make sure you're doing it correctly. And that may be hard to do by yourself. So if you're at all worried, that you're not engaging the right muscles or you're not squeezing the right thing, ask for a referral to physical therapy. There are also devices you can buy online that give you feedback about whether you're squeezing the right muscles or not. Some of them even have like little video games attached to them. So you can buy kind of at-home pelvic floor trainers as well that can help give you feedback about what you're doing.
Okay. This person has an interesting question. They had rectal cancer and have a prolapsed bladder. So they're also experiencing a loss of bowels. So
Hmm.
should she see the gastroenterologist or the urogynecologist first?
Probably just both
Okay.
would be my answer because a urogyne can address the bladder prolapse and also address the loose bowels, but the GI can also, come at the loose bowel movements from a different perspective. So I think both would be a good idea with somebody with that history.
Okay. And you mentioned that you work closely with Dr. James
Mhm.
in Oakland, who is the GI contact there. Um, does placement and removal of the pessary ever stretch or stress the muscles and have a negative effect long term?
It's a good question. It does not, no. Sometimes placement and removal can, be a little uncomfortable depending on if patient has like some atrophy or some thinness of the vagina. But it's not going to cause underlying damage to the pelvic floor muscles.
Okay. This person says they think their issues are related to connective tissue disorder. Is that something that she should start with her primary care physician, a rheumatologist, or make an appointment with a urogynecologist?
Um, if you want to get tested for connective tissue disorders, I would go see, like maybe your primary care doctor or rheumatologist. But if you're having prolapse or issues with your pelvic floor, you should just go see the urogynecologist.
Okay. This person is saying that she was told she has stage 4 um prolapsed bladder for about 7, 8 years and bleeding hemorrhoids after a doctor put a pessary in and it started coming out. And she says it caused a prolapsed bowel. Does that make sense to you?
Um, I don't I don't think it probably would have caused prolapse bowel. It's possible there was already like a rectal prolapse there or some kind of bowel prolapse that may have just maybe been exacerbated by an exam or maybe the hemorrhoids got worse. But I would definitely recommend seeing if they're worried about like a rectal prolapse, seeing a colorectal surgeon. And if there's also pelvic organ prolapse, then they can work in conjunction with a urogynecologist like myself.
Okay. This person is asking if you are an average woman, so to speak, with no disease, but had children and are now in menopause, experiencing symptoms for the first time. What would be your first non-invasive recommendation to address the problem, assuming that it's pelvic floor disorder?
I guess it depends on what the actual problem is. I will say though, in general, if it's like pain or overactive bladder, things like that, then maybe some vaginal estrogen would be a good idea, along with pelvic floor physical therapy. But that's a little bit of a broad characterization. So it really just depends on what the actual problem is.
Okay. So if you have any of these conditions that you talked about and you do go see a urogynecologist like yourself, do you continue to have appointments with your urogynecologist annually, or is that something that you then move the care to your gynecologist once you've been treated?
It depends on what the issue is. It depends on the treatment goals. In general, urogynecologists don't do like annual visits. But depending on what the issue is, like if you have overactive bladder and you're on medications, you'll probably want to be seen by them, maybe every year or so just to check in, make sure everything's going okay. It just really depends on what the problem is. But in general, once the issue is resolved, usually those patients will go back to their primary care doctor, their OB/GYN.
Okay. And do you know, does a patient require a referral to see a
No,
urogynecologist? No. Okay.
no, I,
That's
I
something.
personally don't require a referral.
Okay, perfect. So that's something they could literally call that phone number on the screen
Hmm.
and make an appointment with you.
Yeah,
Okay. Are there over-the-counter pessary devices?
it's a good question. I'm not sure. I do know that with, I think maybe a prescription or even maybe without, patients can buy like a pessary device. There's a lot of innovation going on right now, like 3D printed pessaries, other kind of pessary-like devices. So that field is kind of rapidly evolving with new technology. I'm actually not 100% certain. If you can probably find pessaries online to buy, I'm not sure. I think the important thing though is pessary sizing can be very finicky. So you want to make sure if you're going to get a pessary, you get it fit so it stays in and it's correct. So you don't spend money on something that's not going to work.
Okay. So if you try bulking as a first step or first treatment and it's not effective, can you then move to another type of treatment or more aggressive technique?
Yeah. Bulking, if bulking doesn't work, it doesn't preclude somebody from getting like a sling. You absolutely can get both.
Okay. Um, Sorry, I'm just trying to read through. Does bulking or any other pelvic surgery cause difficulties with sexual activity?
Um, so it shouldn't, no. In general, almost all these interventions I've talked about should not impact your ability to have like comfortable and enjoyable intercourse.
Okay. This person, it sounds like they're in the beginning, early annoyance stage of bladder leakage.
Okay.
What may be a typical time frame for pelvic floor physical therapy? So I'm assuming that means, is it like a 6 week therapy or is it something?
Yeah,
Okay.
yeah, that's every therapist kind of has their own treatment plans. I feel like on average, most people are going to see their physical therapist maybe every week for like 6 to 12 weeks. It really depends. And then of course you can get discharged from physical therapy at any time depending on how you do. So it really, again, these are tailored approaches to each individual person.
Okay. And you did talk about performing an ultrasound at that initial appointment.
Mhm.
Is that something you recommend before pursuing any kind of physical therapy?
No, so that's just it's called a bladder scan. It's just the only ultrasound we do is once you pee for us, we just bring you right back and we measure how much is left in your bladder. So it's just a measurement to make sure no a patient isn't like retaining urine. So that's just part of like the office visit. It's not like a thorough ultrasound looking at any pelvic organs or anything like that. It's just checking for if there's any residual urine left.
Okay. This person it was recommended to her to go to pelvic floor PT because she's getting spasms in her urethra. So
Hmm.
her physician says that's common in hockey players, which she is not, she says, but very active and does functional weight training several times a week. Is that something you've heard of, a spasm in the urethra from that type of exercise?
I mean, definitely your pelvic floor is totally interconnected with everything. So if there's any sort of like pelvic floor strain, nerve impingement, like just a high tone muscles down there, meaning that they're just kind of chronically tight, it certainly can kind of affect like urethral pain. And urethral pain is incredibly challenging to treat, but pelvic floor physical therapy is certainly a first line just because everything is interconnected in that area, everything. So if something is off or tight or a nerve is pinched, it can result in urethral pain. So certainly pelvic floor physical therapy is a good idea.
Okay. And there are a couple questions about having an overactive bladder or incontinence after another procedure, like a hysterectomy or
Mhm.
the gastric sleeve. Is that something you see patients for?
Yeah, definitely. And I do see that in patients. It's not and it's hard to say why that's happening sometimes. For a hysterectomy, maybe the pelvic floor and the anatomy and kind of the angle of everything has changed. Gastric sleeve, not sure why. Maybe it just depends on if you get the weight loss from it or whatever is going on. But certainly, regardless of if you've had surgery before and then you have this, it's still something we can get fixed.
Okay. If you're taking a medication and you're going to pelvic floor PT and you are having some really good improvements, is it possible to stop the medication and test to see, where you are in terms of your symptoms, or do you
Yeah,
recommend getting your medication?
absolutely.
Okay.
You can always, kind of stop it and see where you're at because then if it doesn't, if it stops working again, you can restart it for sure. If a patient wants to get off medication and they're having success, it's definitely worth the conversation as long as you stick with the physical therapy exercises.
Okay. Okay. It sounds like this person's asking about different types of pessaries. They use a ring pessary,
Mhm.
but it sounds like that's a conversation with you to decide exactly what type would be the best for
Yeah,
you.
everybody, it depends on the prolapse. It depends on kind of how open the vagina is. It really everybody's anatomy is a little different, so that's why it's important to get sized by somebody who has experience in doing that.
Okay. And if you are treated using medication and your symptoms go away for a while, but then start to come back, is that trying to find a different medication or are you kind of moving on to another, maybe a surgical treatment at that point?
Yeah, that's definitely an individualized situation because there are plenty of patients who, may want to jump to another medicine. You can always try to increase the dose as well of what you're on if that medicine allows it. Or if you tried a medicine and you don't want to do another one, you can always look at kind of like a Botox or that neuromodulator device. Gets a little tricky because insurances do want to see that you've tried. I think most of them want to see you've tried like maybe two medicines, unless you're able to say like I refuse that therapy to get approved for the next one, but I rarely have issues getting kind of like those more further downline treatments approved for patients.
Okay. I am going to apologize in advance. I'm not sure I'm going to pronounce this word correctly. Is there a relationship between interstitial
Cystitis.
cystitis or and pelvic organ prolapse?
That's a good question. I tend to not see prolapse and I see interstitial cystitis together frequently, mostly because a lot of the patients who have interstitial cystitis may be on the younger side versus prolapse patients, maybe a little on the older side. Also, a lot of the times interstitial cystitis is related to more of like a tight or high tone pelvic floor issue. It's more of like in the syndromes of pelvic pain. And so a lot of times if patients have kind of a higher tone or tight pelvic floor, they may be a little less likely to have that prolapse, but certainly they can overlap. They're not really related though, per se.
Okay. We have another question about the recovery period. So we talked about kind of 6 weeks before you feel a little bit more back to normal. Does that mean you're off work for 6 weeks, like including a desk job, or is that just the
That's an
total?
individual, yeah, that's an individual, thing. Personally, I'm happy to allow patients to go back to, lower intensity jobs sooner if that's what they want or if that's what needs to happen. We're definitely studying in the field now if our restrictions are too cautious. Can people go back? Can people lift a little bit more than we tell them to? So I may be liberalizing my own restrictions at some point, but absolutely desk jobs, if you're feeling up to it, you can go back sooner.
Okay. If you are someone who has had a hysterectomy, are there activities that can cause prolapse, like running, for instance?
Not generally. And I try to tell patients who, even if they have prolapse, you're not going to make it worse out of the blue. Like you shouldn't stop doing your daily tasks. You shouldn't stop doing what you're doing out of fear of making something worse. Certainly, but at the same time, if you're doing a lot of heavy lifting, if you're doing all this other stuff, like not necessarily like working out, but if your job involves a lot of heavy lifting, lifting patients, what have you, certainly it can probably make it a little worse, but running, doing day-to-day stuff. Like I tend to tell people don't limit your normal life for something like this, especially if we're going to fix it.
Okay. Is there any special care needed with a pessary in a dementia patient?
So I think the most important thing about pessaries with dementia patients is you make sure that somebody is taking it out every couple months and cleaning it and put it back in. Because if you leave a pessary in for too long, you can get like rug burns or erosions in the vagina that can start to cause pain and bleeding and problems. So as long as that person's under care of somebody and getting it taken out and cleaned every few months, it's okay.
Okay. Have you had patients find Pilates to be helpful?
I think anything that kind of improves pelvic strength, that improves core strength, that improves like gluteal strength is a helpful thing for people with pelvic floor issues for sure.
Okay. Can you talk about what, and I might say this word wrong too, a cystoscopy?
Cystoscopy, yep.
Yes. Can you talk a little bit about that? And then it looks like we have a couple questions about it. One is just asking what it is. And
Sure.
then other patient is saying they had a bad experience with a doctor that attempted one and they're a little bit nervous to do anything
Okay.
following that. Can they see you?
Sure. So a cystoscopy is a very minor procedure where you take a small little camera it's kind of like the size of a catheter, and you take a look in the bladder through the urethra. It's if it's just for diagnostic purposes, so taking a look around the bladder, making sure everything looks okay and healthy, or looking for, something that may be problematic, it usually takes about 30 seconds to a minute. A lot of places do that in office. I like to do it in office, but we don't have the equipment in Bloomfield yet, so I do it at Trinity Health Oakland. Um, so getting it done there actually gives you the ability to get a little anesthesia if you want it, but in general, it's such a quick procedure, and we do put some numbing gel down there that most patients are able to tolerate it very well in the office. I just don't have the equipment for that yet, but I do offer it. We just have to do it at the hospital. It's more of a diagnostic procedure in that setting than anything. Of course, it comes with doing something like that Botox or the bulking. It's part of it, but on its own, it's more just diagnostic and it's incredibly quick.
Okay. And just do a time check here. We're a few minutes after 8. Are you still okay to answer a few more
Oh,
questions?
I can keep going.
Okay.
I think my 3-year-old's asleep, so we're good.
Okay. That's key.
hmm
Okay. So you talked about that bulking. You talked about bulking, and then you talked a little bit about if it's too much. So
hmm
what do you do when that happens? Like if someone goes home
Sure.
and they kind of call you back and say, I think it's too much.
Sure. Yeah. So when we do those procedures, we monitor very closely to make sure you as a patient are able to pee. And if you can't or you're having trouble emptying it, it's actually very interesting. The material is like a gel and it doesn't kind of settle or harden right away. So we're able to kind of put a little catheter in to kind of almost mold it or push it out of the way to let that opening widen a little bit. And then generally you're able to pee. Bulking is 100% reversible from that standpoint, so it's never permanent. Like we'll never do something like that, and the patient will never not be able to go to the bathroom. We will always be able to reverse it.
Okay. Okay. Someone's asking just a basic question about how long between cleaning the pessary. I think you just mentioned that.
Yeah, about 3 to 4 months is
Okay.
probably 4 to 5 is probably the most you want to go. Just because it can create a discharge and can start to, have a little bit of an odor and things like that. So, probably 4 or 5 months at the max.
Okay. And if somebody has mesh, it sounds like this person has it in a couple places. Um, can mesh be removed? This person was told that you cannot remove it because it'll cause issues.
Yeah, so it really does depend on what mesh we're talking about. Whether we're talking about a sling, it does depend on what type of sling, or if we're talking about that prolapse or sacrocolpopexy mesh. There also is a mesh that is put in through the vagina for prolapse. That's the stuff that kind of was taken off the market a few years ago now by the FDA. That was kind of the mesh that was all the lawsuits and people had the pain and trouble with. Um, in general, mesh can be removed. It depends on where it is and what type of surgery it was put in for. Usually, it's a pretty morbid procedure if it's more of like the mesh for prolapse, just because of how much it's usually scarred in. Usually, if it's like a bladder sling, it's a little easier to take out. Can be done. It just depends on each individual person. It's a tough surgery sometimes, but it's definitely doable.
Okay. How would pelvic spasms appear in a young woman who hasn't experienced trauma? Is there a reason that that would be happening?
Yeah, so I see a lot of patients who have some pelvic floor dysfunction or spasms. It can really be anything. It could may have been maybe one UTI. It could be just anxiety and stress, and then there's this kind of pain cycle or like spasm cycle that happens that at some point it's tough to break on your own, even if you're not kind of consciously doing this. And that's where physical therapy helps. That's where some medications help. That's where maybe injections help. So it doesn't have to be from trauma. It can be really anything can set it off, and then you end up on this like cycle that's hard to control.
Okay. You talked about putting the key in the door and then all of a sudden you have to go to the bathroom like now. So this person's asking about cold. So in the winter going outside
hmm
causes urgency, and in the summer going inside to air conditioning causes
hmm
urgency. What's happening there?
Yeah, it's a good question. I don't know if I have a perfect answer, but I certainly, for whatever reason, the cold certainly can trigger urgency. I don't have a good explanation for it, but that certainly is something that people experience.
Very interesting. If you're doing when you're doing your initial examination, are you able to see cancers or different issues that you may need to refer the patient to someone else to treat or see?
It just depends. It's tough, if somebody's having like bleeding after they've undergone menopause and that requires kind of a cancer workup. If somebody maybe has something that looks atypical on their cervix while I'm doing an exam, I would work that up. Um, but cancer, especially gynecologic cancer, could be so difficult to detect that generally it's not something I'm seeing frequently.
Okay. This person's asking about Botox. They had it work successfully for about 2.5 years and then stopped. It's been about 5 years. Can they retry Botox again?
Yeah, absolutely.
Okay. Um, does stress incontinence necessarily always lead to prolapse later in life?
No, they they may have some interconnection relation to each other, but there's plenty of people who have just stress incontinence or have just prolapse. Having one doesn't mean you're necessarily going to have the other and vice versa.
Okay. I'm just going to scroll through quickly, Dr. Ross, if you can bear with me for a moment. There are a lot of questions about your location. So again, you are in Bloomfield Township.
Yes, I am
Technically,
in Bloomfield. I operate out of Trinity Health Oakland, and that
yeah.
is my only location at this time.
Okay. And the Bloomfield location is right at Woodward and Square Lake, which is a super convenient area if you're not familiar. We will share other locations, but Dr. Ross is the only one in the Oakland area that is practicing urogynecology. Okay. Sorry, I'm just going to scroll through quickly. Um, oh, someone's asking about coconut oil. Um,
There.
there's that. So, what about using coconut oil for sex to relieve pain or to be used with pessaries?
Sure, coconut oil is a great vaginal lubricant.
Okay.
Absolutely. I don't know about pessaries just because I don't know how coconut oil reacts with like the silicone of the pessary.
Okay.
But certainly for like vaginal lubrication and intercourse, absolutely, coconut oil is great.
Okay. And someone is asking why tea is bad for the bladder. I've never heard that.
So tea has some chemical compound in it. I'm not sure what it is. One, caffeine certainly is, and then two, some teas have certain chemicals in it that just can irritate the bladder wall, especially if you already have a little bit of a hypersensitive bladder from like the overactive bladder. It's going to make it worse.
Okay. Okay. How commonly does Botox require catheter use due to too much bladder stiffness?
It's a good question. Usually it's around like less than 5% of patients require some sort of catheterization after Botox. Um, it also is a little bit more common as you increase the amount of units of Botox you use. I always try to go with the lowest, which is 100 units of an injection. And usually patients don't have much of a retention issue. But I certainly make sure everybody's aware that that's a potential side effect or complication related to Botox injections before we do it. I don't want anybody to have any surprises that they may need to catheterize.
Okay. This person takes Lasix. So any suggestions as she has no time to get to the bathroom? That's an
Yeah.
interesting combination.
Yeah, it's tough when you're on like Lasix, which is a water pill or a diuretic. Can try to depending on what time you take it, it may impact things. Certainly, it's better to potentially take it so you're mobilizing all your fluid before you go to sleep, because a lot of the patients who are on Lasix are getting up a lot at night to go pee. But you also have to kind of weigh the risks and benefits of what the Lasix is treating versus the incontinence. And always worth a conversation with whoever is prescribing the Lasix, whether there's an alternative option.
Okay. All right. I think we have one more here that we haven't asked yet. So this person doesn't have issues during the day, but then has to get up 3 to 4 times a night. I wear Depends so I don't leak. Is this a result of prolapse?
It could be. Definitely requires an exam to know for sure. Certainly sounds like a little, at least overactive bladder. There are a couple other conditions that are just kind of nighttime urination, and that requires more of like keeping track of how much you're peeing at night, in like a bladder diary, but certainly worthwhile seeing somebody to talk about treatment options and diagnosis.
Is it typical that someone could have more issues during the night, or is it just more noticeable because you're actually waking up to go to the bathroom versus, you know, during the day when you're already
Hmm.
awake?
No, there are definitely plenty of people who suffer just from nocturia, which is the going frequently at night, definitely. And it's certainly something that can be treated similar to overactive bladder, depending on what's going on.
Okay, I did find one more question. If the pee stream goes anywhere but straight, what is that a sign of?
It depends. It certainly depends. Would definitely need an exam to figure that out. Could be pelvic floor issues. Could be there's prolapse and something kind of in the way of your pee stream. Um, it could be other things as well. You would need to see somebody and get an exam.
Okay. Okay. I think there's one more question here that someone just dropped in. Can prolapse increase flatulence?
It depends. If you have more of like that rectocele or that kind of posterior bottom wall prolapse, it may cause more issues with the bowels. It really depends on what's going on down there.
Okay. All right, perfect. Thank you so much, Dr. Russ. That was a marathon of questions that you.
Yeah, I love doing it though. Thank
Thank
you.
you.